All right, so we're going to get started. Hello and welcome, everyone. Thank you for joining us today for another Minnesota HIMSS webinar. We're going to be talking with Dr. David Ingham about virtual care transitions for Allina Health, and as well as answering any of the questions that you might have. As a set of reminders, we are going to be recording today's event. It's made available after the fact then for all Minnesota HIMSS members, so you can send to any of your coworkers or colleagues that might want to watch it. If you are interested in being a speaker or a sponsor for any of our future webinar events, please feel free to reach out to Minnesota HIMSS at mn.himsschapter.org, and we will take a look and let you know. We will be doing a Q&A at the end of today's session, so please feel free throughout the presentation to add any questions into that questions section. It shows up on the right-hand side of your GoToWebinar. And then we'll be reviewing those with Dr. Ingham at the very end. So just as a brief introduction, Dr. Ingham serves as the Vice President and Chief Health Information Officer at Allina Health, leading and advancing their healthcare informatics within the organization. In addition to guiding deployment of applications that impact clinical care, Dr. Ingham is responsible for understanding and monitoring the digital health tech landscape and assisting and steering Allina through the ever-changing environment. He has a firm belief that that patient care is the core to all human-to-human interaction, and is passionate about leveraging EHR and digital health technology to support and augment that interaction. In this role and in previous roles, Dr. Ingham has led countless efforts to improve patient care while simultaneously reducing the cost of care. Dr. Ingham maintains a small primary care internal medicine practice at Abbott Northwestern General Medical Associates. He's also active in education for internal medicine residents at Abbott Northwestern and medical students from the University of Minnesota. Dr. Ingham has research interests in hypertension and preoperative care. He's published articles in peer-reviewed journals on those topics and others, and is part of multiple ongoing clinical studies. So thank you again, Dr. Ingham, for joining us to present today. I believe you've got your presentation pulled up and you are ready to go whenever you are.
Thank you for that intro too. It sounds pretty good. I don't know where that came from, but thanks for having me. Happy to be here to talk about some of our experiences at Allina the last few months as we have dove headlong into the virtual world. And as mentioned, I think many of you are probably familiar with Allina. We're headquartered in Minneapolis. And as mentioned, I serve as our Chief Health Information Officer, and I have no disclosures for today. Just a little bit of a preview here. I'm going to cover a few different topics. First, our ambulatory journey through the COVID times and how we built out our virtual care program. And then a little story about what we've done in the hospital side to help support care in that space. And then a little bit, I'll venture to describe a little bit of where I think or hope virtual care is going, and then perhaps how we will know when we've succeeded or how we will measure our progress. So first off, ambulatory care, and I titled this section "Keeping the Lights On During COVID" because that's pretty much what we were trying to do. And to give everyone some background, back long ago in February, Allina had a very small virtual visit program on the ambulatory side. We did maybe 50 video visits per week. We had a couple hundred providers who were trained, but not a lot of regular users in that area. And I joke that most specialists said, no, it wouldn't possibly work for us. Insurance, they will pay for it. And PCPs are like, well, why bother? And famously I used dermatology for the specialists because they said it couldn't possibly work. No, I have to see people in person. Well, fast forward to March. And some of you may be familiar with the novel coronavirus. Of course, we're all extremely familiar with it, but COVID comes along and all of a sudden our in-person office visits, of course, plummet. And the scale here, I think it's a couple thousand visits per line or something like that. You can see it absolutely fall off a cliff like so many other health systems and clinics. And so we started asking questions, boy, we've got a lot of people out there who still need to have care. How on earth are we going to avoid exposing everyone to COVID? and uh-oh, how are we going to pay the bills? Because Allina, like so many health systems, run a pretty tight margin when it comes to those things. And all those folks before started screaming that we need virtual care right now, and including myself, as we started looking at the real situation. And so what did we do? Well, I'm simplifying here in this little story, but 3 folks we got together, our head of IT infrastructure, myself, and our vice president of medical operations. And basically we said, boy, we've got to make this virtual care happen, and we need to make it happen right now in terms of having video visits and other ways to support the care of our patients in the outpatient world. And so basically we said, we're going to do this. Our VP of medical operations, Dr. John Misa, and we sat down, and I don't think I'll ever forget these like 2 to 3 hours. We just sat down and mapped out, not every detail, but basically what we thought we needed to do to make this happen. And it was pretty intense. We had big whiteboards and piece of paper that we were using, sticky notes and whatnot. This is back in the olden days when we could be in the same room within 10 feet of each other. Meanwhile, our Chief Technology Officer, Tom Bethke, said, guys, we're going to need a little more bandwidth to do what you are mapping out. So that afternoon, again, everyone's energized. We're all fired up. We're going to go after this. Got all our key people together for that afternoon, sort of manager to director type folks that are really key to the day-to-day operations. Basically had a lean event showing them what we're proposing and walking through what decisions are needed to support a giant leap into the virtual care world. Meanwhile, Tom says, I'm going to need more bandwidth. And his reaction actually was a little bit like in that movie Jaws, for those old enough to remember, where I forget if it's Richard Dreyfuss or who sees the shark on the side of the boat and turns around and says, we're going to need a bigger boat. That's kind of Tom's reaction, saying, we're going to need more bandwidth. And the next day, our informatics teams were working just nonstop, templates, visit types, all these types of things in order to support the workflows, support the scheduling process, figuring out how are we going to know which patients are actually still coming in, either because we can't get a hold of them or they want to or whatever, which ones are going to have virtual visits. Meanwhile, our operations people are trying to frantically train everyone on what's going to happen the next day. Tom's still saying, I think we need more bandwidth. And so Friday, we went live. We went live with 2 main things. One is phone visits. So this, I think others probably have developed this sort of thing. Phone visits were our main thing to start, where a clinician calls the patient, basically tries to mirror an in-person visit as much as possible by walking through problems, evaluating, managing, and whatnot. And then also went live with our video visit access point, which again was building off something that we kind of had before, but not nearly on the scale that we needed. And Tom kind of held his breath. And so what happened? Well, actually, everything went great. We had no problems, and that was the end. Well, not exactly. We had a few issues that came up in the coming days and weeks. It was kind of a good, bad, and ugly situation. We did really well with phone visits. We scaled that a couple thousand daily. Like we went from 0 to 2,000 in just a couple days. It was really phenomenal. Our video visit side of things went from, again, roughly 10 a day up to about 1,000 a day. I was pretty pleased with that. Trained a bunch of people, but not everything was good. Tom was nervous. We're tapping his bandwidth ceiling way too frequently, and things are cutting out and whatnot at times for people. Especially, really the biggest trouble came at these peak times. So like 1 p.m. to 2 p.m. when you have tons of people on. 8 a.m. to 9 a.m. Those were our trouble spots, and we'd all kind of hold our breath during those times. We didn't have enough webcams, we didn't have enough microphones. And the bad part was, of our video visits, about 20% were failing. When I say fail, meant that there were troubles such that the clinician had to say, hey, you know what, let's either switch to our backup video platform. Actually, we didn't have one at the time, but so mainly was switching over to a phone call, which is not terrible, but not optimal either. And then as best as we tried with, operational pieces around how do you get labs? What if someone actually needs to listen to the patient's heart and lungs? How do we arrange that? It was bumpy, to be totally frank. Week 2 was a little better. Still a ton of phone visits. We did more phone visits than I ever imagined possible. A lot more video visits. We've kind of got the bandwidth stuff figured out. Tom was hooking up, more switches, more routers. I think I forget how many new T1 lines they hooked in. We still don't have enough webcams though. I joked that by day I worked, in our informatics team, and by night I would drive around to Best Buy and Target and Walmart just searching for more webcams. It's only partially a story there. And then we still had, a lot of failover visits moving over to phones. So that was not ideal, but that's kind of what it was in those early days. And so when we looked at how we scaled and tried to get a sense of where we were relative to others in the country, Allina, we scaled pretty darn quickly in our virtual care world. This graph on the left shows our numbers relative to baseline, which is defined as kind of that, I think it's the last week in February, first week in March as your baseline. And then where were you as a percent of that as far as the total number of virtual visits you're providing. You can see we accelerated pretty darn hard there in the latter half of March and plateaued, and then coming down some. I don't have additional data available for today, but everyone has kind of leveled out as in-person has come up, and but we still are providing a substantial amount of virtual care for our patients, somewhere in the order of about 20 to 25% each day. You can see here on the right how our percent of care delivered for a couple different specialties in our primary care service line. Derm, it was so timely because we had talked to them about, well, would you be interested in virtual care or televisits just a couple months before COVID hit. And again, they said, absolutely not, would never work. And they turned out to be one of the biggest users, absolutely loved it. And of course, they do need to see people in clinics sometimes for biopsies or for scrapings or whatnot. But dermatology went from, one end of the spectrum to total advocate, and that was really fun to see and to work with them on. Within the clinic visit space and virtual space on the ambulatory side, there's still a lot of risks. I'll touch more on these after a while, but billing continues to be an issue. Phone visits, they make me really nervous. If people ask what keeps me up at night, it's reimbursement of phone visits. We know that reimbursement will occur for what's happened so far, but I really worry about after the national emergency, if we're still doing substantial phone visits, what does that look like? Many of you, I'm sure, know that prior to COVID, reimbursement for a phone visit, even if it's a really substantial visit, again, on par with an in-person evaluation and management, the reimbursement is really quite poor and not something that's sustainable from a business model standpoint. I worry about the documentation requirements. Our informatics teams and operations teams work really hard with billing compliance and others to figure out what exactly do we need to be documenting in different visits. On the whole, I used to joke that our compliance and billing people would probably throttle my neck if they ever got a hold of me, because we were running so fast and so hard to start with, and we were stretching them way outside of their comfort zone and doing new things faster than they could read the various policies and regulatory documents surrounding it. And there's still regulatory questions. I'll touch a little more on these later. What if a patient's out of state? What do we do? What if the physician's out of state? Getting signatures and making sure we have consent and things like that are just a few of the ongoing risks that worry me. As I look to where virtual care on the ambulatory side is likely to go, boy, I think it's going to depend a lot on COVID. We've already seen as COVID fear has diminished, and also the COVID numbers have diminished, so kind of two sides of it there. Demand for virtual care has come down some. There's still quite a bit of it, but I strongly suspect that as we see additional waves of COVID in the, or potentially in the coming months, I suspect we're going to see resurgent demand for virtual care. And though right now we're kind of breathing a sigh of relief that people are coming into clinic and whatnot, I suspect that having a really flexible care delivery model is going to be critical to handling different waves of COVID. And a lot of questions around, so HIPAA, of course, has been relaxed. Within Allina, we prefer to still use a HIPAA compliant clinical video platform, but these rules have been relaxed for the time of the national emergency. So how long will that last? Reimbursement rules make the news a lot with our politicians in Washington going back and forth about whether to continue reimbursement rules around it. And I think that will weigh heavily on the future of virtual care. McKinsey, I came across some interesting numbers I thought I'd share. There, of course, everyone's kind of making this up, but what % of ambulatory care should be virtual? Not that will be, but should be. And I think these are pretty good numbers. If we look at primary care, 30%, that seems like a pretty good spot in my mind. Especially certain types of visits really lend themselves to that virtual interaction, where it's diabetic checks, potentially blood pressure follow-ups, post-hospital visits. So I think that's a really pretty solid number. Within urgent care, I'm very interested. How can we use virtual? Oh boy, excuse me while I find my slide again here. How do we use our virtual means to reduce the amount of pressure on our ERs and urgent cares? And I'm not quite sure what's going on with that. Most of my friends at Allina like to chuckle when the IT guy has trouble with tech. Well, I'll just keep going like this. Sorry, everyone. And then home care, I think, is a space that really has some great potential to really lend itself to additional, virtual care and whatnot. And so now I'm going to shift gears, if I can, into our hospital space and trying to connect our patients while still preserving PPE and still preventing COVID exposure. I'll tell a little bit of a story what we did in this space. So again, going back to this mysterious bug, the coronavirus, and when it hit in mid-March, we were looking at, as all of you were too, what happened in China, what was happening in northern Italy, in France, in these other early hotspots, and the lack of PPE. We're also, like everyone else, worried, how are we going to avoid exposing each other and our patients to this new disease? And so we started kind of thinking in the hospital space and ERs in particular, where we have a lot of computers in there. We have patients who are sitting there in kind of the same spot for their time. And boy, we sure have a lot of FaceTiming and other things going on. So we kind of started scratching our heads. Is there some way that we could pull those pieces together in order to communicate with our patients and maintain that continuity of care? And what we came up with was what we call Teams virtual links. These are, the short version is there's a tablet inside the patient's room with an audio visual, so FaceTime-like connection to a viewing station that's outside the room that clinical staff can use to communicate with that patient. So just tell you a little bit about what we did and how we did that. And so in theory, well, that should be pretty easy. Like you get a tablet and you hook in a FaceTime-like connection. Well, if you want to do it for 900 beds, which is what we were kind of thinking would be our ballpark, to cover all of our ERs, ICUs, and COVID units, things like that. Also our urgent cares, I didn't mention that. But somewhere in that 900 range, that's a lot of devices to manage, keep secure, and deploy. And oh, by the way, they need to be really easy to clean. They got to be mobile, and they have to be so easy to use that even my tech not savvy friend, doctor friends can use it. So that was not an easy task. But our going back to my friend Tom, our chief technology officer, he and his team got to work, and it was quite a feat. I got a few different pictures here. So the idea was to connect the tablets onto stands that were mobile and had goosenecks, so we could kind of lean it in over a patient for ease of use and whatnot. And you can see the first shipment of stands here on the upper left. I think that's like the first couple hundred or something. So those had to be all put together. You can see stacks and stacks of tablets, and the guys had some fun. Guys and gals had some fun with the boxes there in the lower left with that first shipment. And you can see them, you got to charge them, to program them. We use Microsoft Teams for our audio visual connection on these, and make sure that they're secure so that patients can't just be going in and doing whatever. And so that was quite a feat. And that's kind of step one. We then have to deliver them. So our truck guys bringing them out, and then bringing them, other IT folks bringing them into the actual hospital rooms and nurses stations and whatnot. And this is all happening in a matter of days. So this is a project that would normally take like a year. I mean, you'd spend like probably 3 months just kind of picking what tablet and what stand and trying different ones. And then, well, we're working on the tech and testing a few, and you go do like 3 urgent care rooms. Well, we just basically programmed a couple hundred, deploying those while programming the next 200, and pretty chaotic to be troubleshooting and redesigning our configuration all at the same time. But it worked out really well, actually. This is one, of course, it wasn't perfect. There were bumps, but I've got the beautiful fake photo on the left here because I don't have they won't let me take pictures in the time of COVID, of course, of a nurse's station. And basically there's viewing stations, anywhere from 2 to 4, depending on the size of the small unit at the nurse's station. And you can kind of beam in or connect in to the patient on the right-sided photos, where again, they can kind of view, and it's really simple. Patient doesn't have to do anything except talk and look at the screen. And what happens is, the doctors and nurses, they just don't have to go in and out of the rooms as much. They can, quickly connect with the patient. The video, at least hopefully, creates a little more of that human connection. And anecdotally, what we found is some units, there is a lot of not quite perfect PPE usage. So in an ER, you're busy. You got to check with the patient. Hey, are you on metoprolol, or is that an old bed? And they just kind of crack the door and ask. And really, they should be gowning and masking and face masking and all this kind of stuff. And they weren't. And so we found that it really cut down on these types of things. Now, not that cracking the door is the biggest exposure risk, but it is a risk. And we want to protect our caregivers and our patients. So we found that was really helpful. When we look at the numbers, by the end of April, so less than a month or maybe a month, we had gotten 700 out. We're all operating. We had trouble getting more than the 700 initially, so we had to kind of stop it after a couple of weeks there, or stop building more. And at the time, for a few weeks, we're doing about 26,000 minutes of live audio-visual connection. I've kind of pondered, is that good? Is that bad? Is it like kind of okay? And I'm not totally sure, but I think it's pretty good, pretty decent, considering that at the time, like many health systems, we had cut off all elective everything. And so our hospitals were kind of like tapping our feet, waiting for COVID surges, and hospitals are running 40% capacity. But I think 26,000 minutes of live video per week is pretty good. And people have asked me, well, how much PPE did you save? How many COVID exposures? And I never have really ventured to make some artificial calculation on that. I'm very confident that we've preserved some amount of PPE and probably prevented some COVID exposures. How many is hard to say, so I kind of leave it at that. But anecdotally, doctors and nurses really like it. One learning, this is kind of a duh moment for me after we started going out. It turns out we didn't need quite as many in the ICU as we did. It turns out ventilated patients really can't use that audiovisual quite as well as patients, say, in the ER urgent care. So that's one learning. Not that it's useless in the ICU, but not quite as helpful as maybe we'd like. And then since then, we've expanded to our mental health units, and we've kind of slowed this down just because the pressure was no longer there to have an out of hospital beaming into those units, but having a remote rounding possibility is something that we have kind of teed up and ready to go, but haven't pulled the trigger on yet. And within Allina, we've done some other virtual care. I won't go into the details on all this. Remote hospital care with e-hospitalist, e-ICU type stuff we're either have or starting to build out. Remote monitoring is a really exciting space. We have a fairly robust CHF monitoring program. But how could we, use remote monitoring for diabetes and some other conditions that perhaps would be amenable to that? Could we equip, say, young moms with a kit that has an e-stethoscope and an otoscope and some of these things? There's different kits out there so that they don't have to drag the kid in every time there's a sniffle or every time there's something. So these are a few of the things that we're just kind of tossing around and looking at how it could fit into our care delivery model. All right, shifting gears to kind of the last section here. What's the future of virtual care? What are some of the assumptions and obstacles that are in the milieu here? And then what can we take away from some of those things to hopefully move this forward where appropriate? So I'd say, the benefits of virtual care, between the, quality being very high, lower overhead, better clinical outcomes, more convenient, real satisfied patients. Well, are those benefits or are those assumptions? I would actually take a step back. These all, I hope are true. I would like to be true, but I don't actually know. We don't have great data to show that we have these benefits with virtual care. We don't have great data to say that, hey, if you manage your patients with virtual, augment the care with virtual, that you're going to have a better quality, that you're going to, spend less money, that you're going to have satisfied patients. I would say that we actually need a lot more information around what the true hard and fast benefits are for virtual care. I think we need more experience with it. Like we're toddling, maybe. We're probably not crawling, maybe we're toddling. And we need to have at least some observational data around, what the benefits, the real hard benefits are. I think we need randomized controlled trials around, do people who have received their care virtually, let's say in the outpatient space, do they do better? Does it cost us less? What are the actual benefits that come along with having a robust virtual care program? I think that's critical, and I'm hoping that we can answer that sooner than later. Tangential to this big picture, I think there's a lot of question around, and I know I question, does virtual care cost more than standard care, or does it save total healthcare cost? And there's a couple different perspectives that I see and I read about and I've talked to people about. First is, well, if you're increasing access and increasing care, they guarantee you're going to spend more. And we have some parallels for that, where if we expand, various insurance plans and other things, like there tends to be more access and more care that happens, so it tends to cost more. Now, whether that's good or bad is debatable, but if we're looking at just a dollar and cents, some people say, now, if you expand the access, you are going to spend more. And is that the direction we need to be going now with the total cost of healthcare that we're seeing in our country right now? Other folks will take kind of a counter position, which I hope is the correct perspective, where, okay, we have more access, we have more care, but that does lead to better outcomes, leads to fewer admissions. We're not having as many complications, and we're able to keep care perhaps more local. So whenever you transfer a patient, first of all, whenever you admit them, it costs a lot more than if you can treat them at home. Whenever you transfer between a facility, it costs a lot more. So whenever we can keep care local, I think that's a good thing. And I suspect that while not all virtual care is going to turn out to really save a ton of money, I suspect a lot of it will in the form of these types of things. And that in the end, I think our total healthcare cost will be lower if we're smart about where we're deploying our virtual care. Of course, there are lots and lots of obstacles to deploying virtual care. When I was talking about our failover rate for video visits, 20%, just, I had to shake my head because it was so painful to have that many visits failing. We had a team work pretty darn hard to get it down. We're somewhere in the 8 to 12% range, depending on how you measure it right now. And, like most tech, I'm a tech guy, of course, I've kind of my skeptical doctor friends say, Dave, it never really works as well as it's supposed to. And I agree with that on some level. I think it works pretty darn well most of the time, but there are things we need to do better. And when we've looked really closely at the reasons that these visits fail, it's like death by 1,000 paper cuts. If you're a doc and you're working from home, it's not only what computer you're using, it's also what your internet bandwidth is. Are your kids streaming YouTubes while on the TikTok while also playing video games? It's those types of things. Patient side, there's so many variables. What browser are they using on what device? Are their kids on the FaceTime or TikToking or whatnot? So it's those things that, boy, we can try to guide folks to the optimal setup, but we can't necessarily force them into it. And so there's a lot of these factors we can't control. On the tech side, so on the tech side, what can we do? So we're working, how can we make our platform as stable as possible, reduce any errors and issues that are happening on our end? And I think going from 20 to 10%, we basically squeezed out all the issues on our side, maybe not all, but most. And there's, but there are these others that we're still working on. And that we do have a video backup, video platform that's a backup. So it used to be if my video visit, we had troubles, well, we just go to the phone. And now we have a backup video system where, hang on, Mr. Smith, I'm going to send you a link, just click that. And it's a really simple, easy to use video platform that is a nice alternative to the phone and kind of helps support that connection with the patient. So a lot of work on that. And tech, I think tech is in some ways the least problematic, but in other ways it's, it can really be an issue. Operationally, it's tricky, as I know so many of you know. If you think about it, for decades now, we have been fine-tuning and honing our clinic operations. We have this really specific process that basically everyone does the same. It's interesting. Patient comes into the front desk, they check in, we check their insurance, get a copay, they wait, they go back, they get their vitals, get the questionnaires, doctor, nurse practitioner come in, they go to the lab. It's really a pretty smooth process, and there are a lot of safety mechanisms and checks in there to do things and help make sure we're providing safe, quality care. And with virtual care, we have just uprooted all of that and are now kind of having to redo it. And so we saw a lot of issues early on with, not doing a good med-rec questionnaires. So we're supposed to do a PHQ, a depression screen on every patient who has certain criteria. And how do you hand someone a piece of paper when they're connecting virtually? And so that's been a struggle. Of course, we can use our tech to help with that. So having more and more questionnaires. We had a few before, but we've got a bunch now. But even then, patients don't necessarily like to fill out the questionnaires online. How do you get vitals, and how do you intake patient patient supplied vitals. That's a really simple question, not a huge one to fix, but it's one of these things. Uh-oh, how are we going to do that? Patient behavior, patients amaze me. Lots of them will be driving in their car and call in for their visit. They'll be on vacation in, Colorado or in Mexico, wherever. And most of the time we think it's probably not safe to be driving while you're having your virtual visit. So a couple of these things we've had to sort of figure out in the work stream. How do you verify insurance, get a copay, all this type of stuff. And probably probably the most interesting obstacle is patient expectations. This has just been amazing to me. The most fascinating one is provider timeliness. So, a normal in-person visit, I show up for my appointment, I'm in the exam room waiting for the doctor or advanced practice provider, and I have my Sports Illustrated magazine, or I'm on my phone, and it's 15, 20 minutes after the appointment time. I don't think anything of it. Maybe you look a little bit at your watch, but really it's like, that's pretty typical. Now patients, if you're not on the line in that video or on that phone, like 3 minutes after the appointment time, they are upset and they are very vocal about it. And so how do we, and it's a very interesting phenomenon, and I don't know if it's something that just there's a different expectation because they're at home and they're on this, but we're working out how do we nudge some of these docs. I'm certainly always on time with my patients. Yeah, right. But how do we nudge some of these docs who are perpetually behind 20, 30 minutes? How do we get them to sort of hopefully be a little more on time? Are there ways we can build their schedule to lump the virtual visits together and have in-person, in the afternoon or something like that to help keep them on time? Virtual waiting room, another one where the patient's sitting there for 15 minutes and it's just a black screen with a picture of Dr. Ingham. And after like 15 minutes of nothing happening, they start to wonder, is it working? And so how can we, and we haven't solved this one, but how can we have some cues in there and other things to help them know, yep, we're still here, we're waiting, we're real sorry, Dave is running late again, things like that. Cost and billing, another interesting one for me. Patients, for a lot of these virtual visits, it is truly on par with being in person. We're managing diabetes, managing very complex things, and the quality, I think, is just as good, but the patients don't expect to pay as much. They think, well, it was virtual, they hardly did anything. It should cost a quarter of what it does when I go into clinic. They didn't have to, pay for a parking spot, they didn't have to whatever. And so it's interesting how to meet those expectations. Some folks find it's not as personal as being in clinic. I don't know that we can fix that one, but we can, within Allina, we've been working on how do we help nudge docs in their, computer side manner and have their virtual visit, sort of personality and how they interact with patients. And then technology issues, of course, folks don't like when the tech doesn't work. And so that's a really important one. Again, I'd like to get have as few tech troubles as possible. Last one, big obstacle. I never thought in my life I would know so much about, medical licenses in different states and interstate rules and all this. Before COVID, we didn't have to think about it. Patients here in the state, and I'm here in the state, and I have my Minnesota license. Okay, we're done. But in COVID, with all these declarations of emergency, lots of states wrote in rules where if I have a license in good standing in state A, then I can practice medicine in state B. And so Wisconsin was one that did this. But there are all kinds of little catches in there. So MDs and DOs could practice in Wisconsin if they had a Minnesota license in good standing, but NPs and PAs could not. They simply weren't allowed. They had to go get a full license. And so, and then the rules are different in South Dakota versus North Dakota. And what about all our patients that are down in Florida? The rules are even different there. In Florida, they said you can practice if you have a license in good standing, but only on an emergency basis and only if you don't bill. And it's like, well, okay. So it's been a real challenge, and all these things are fluid and moving. So Wisconsin ends their their state emergency, and suddenly the rules are different. You have to have a license in that state and be in that state. And so, or not be in the state for telehealth, but have a Wisconsin license and the patient be in Wisconsin. And then it's even different for PT, psychologists, all these. And so I kind of do the head slap emoji kind of thing on this. And the way we've approached this at Allina is to sort of keep it simple. When it all started, we had this big grid with kind of the Midwest states and the rules for it, and then kind of Arizona, Florida, and who could practice where and what it was. But we could see that that was not going to be sustainable. And so we developed some kind of guidelines where, boy, if it's your patient, you know them, it's a relatively simple problem, or say your partner's patient and it's a pretty simple problem, they're not in the same state as you, it's probably reasonable to provide the care because, again, the patient is still our priority. And we need to keep that in mind. And yeah, it may not be perfectly in sync with the rules, but boy, wouldn't you rather take good care of your patient? And this is in contrast to perhaps a new patient or someone with a really complex problem who's in another state. Those probably best, or we sort of guide folks to refer to the local urgent care or to a local, to seek care at a local facility. Another factor would be, wait, are they have they moved to Texas, or are they visiting their elderly parent who's ill for a week and helping them? And so leaving some room for clinician judgment in when to provide that care, when maybe to steer away from it, and helping docs kind of understand what the different scenarios are. But again, keeping patients as the priority. So I kind of asked myself, boy, is virtual care, is it an investment or a gamble? And when I really come down to the tangible benefits of virtual care, I see a few that I think are pretty firm, and I think do tilt it more to that investment side. We've seen our post-hospital 5-day follow-up rates like skyrocket. We were okay before, and we're pretty good now. Now, whether, of course, there's controversy whether that means fewer readmissions. There's, some association there, but we don't have stellar data on that. Other things like, I think we will see fewer transfers between regional hospitals into the metros, our metro hospitals. That's pretty tangible. It's pretty real. We're definitely seeing fewer no-shows. So instead of, I forget what percent, 5-7%, something like that, we're seeing like a 2.5% no-show rate. It's really interesting. And some of these are a little softer, a little squishier, a little lower total cost of care for many chronic conditions. I strongly suspect we'll see that for some things, but as I mentioned before, I think that needs to be proved out. What can we do to really tip it more in that investment direction? I think organizing around your virtual care program. So you can see it's pretty complex within Allina. These are all the different spaces, all the different stakeholders. So I call it kind of wrangling the beast. We have so much work going on in so many spaces. How can we stay organized around that? And I tend to break up virtual care into 2 big buckets with a third bucket in the middle, I guess. So kind of ambulatory and those clinic visits, and e-visits, asynchronous messaging visits. And then on the hospital side, our Teams virtual links that you saw a demo of, or a little story of, traditional telehealth. So doctors in a hospital using a computer cart at another facility that has a stethoscope and this type of thing there. And there's kind of some overlap with really interesting and really niche spaces, particularly in mental health and senior care. And there are unique challenges in some of those. So senior care in particular is interesting. How do you provide care for an older patient in the nursing home who's hard of hearing and maybe has some memory troubles? Boy, that's a tricky one. And so, other things like in mental health, what about partial hospital? What about group visits? So each have their unique challenges, and it requires kind of a mix of those 2 hospital, telehealth, and ambulatory spaces. This is how we organize within Allina, a big picture, of course. We have a steering committee for each side. I think the experts and the executive folks that we need for each of these different areas is different enough. Of course, there's some overlap of individuals, but we see different folks being needed for different sides of the house there. Operations, we always like to have operations running the ship. all those obstacles basically roll up into one of these 4 buckets. And within our IT, our billing compliance bucket, there's like 3 or 4 sub teams that are each trying to solve different problems. But this is roughly how I think is a pretty reasonable way to organize around it. It's taking us quite a while to pull everyone together to really rally around this model, but we've really finally arrived there, I think. A couple other factors, I'll be wrapping up here in just a moment for some questions and comments and whatnot. Reimbursement is going to be the biggest thing. So is CMS, our commercial payers, going to continue paying for virtual care? I have no idea. The one caveat, the asterisk there, that I'll comment on is, boy, if you're in a fee-for-service model, it's critical whether they pay. I mean, you can't do virtual care if they don't. But, if you're in a heavily risk-based contract situation, or a lot of the care you deliver is through a capitated payment model, you could see how, boy, if it's cheaper to provide virtual care as opposed to in-person, you could really augment your care delivery platform with virtual means. And I think, again, needs to be targeted, needs to be the right spaces. But within Minnesota, we're largely in that fee-for-service world. But as some health systems, as we start to really shift into more and more risk-based contracts, more and more capitated care, what will that mean? Of course, you got to execute, you got to have good experience and whatnot. And then COVID, of course, is going to be a wild card, I'd say. And then the real question: do patients really want it? They say they want it, but I'm curious how it'll pan out long term here. This is just a little bit of a summary. The broader landscape, I won't go into the details here, but I break it up into kind of 3 different areas, sort of the teledocs and MD, kind of the national virtual care platforms, independent practices, and then health systems. Each has, I'd say, different strengths and weaknesses as we all sort of shift into this virtual care world, or possibly shift. And I think there's a lot of room for partnerships. And I think it's going to be very interesting to see which ones are kind of partnering, which health systems are really building out their own system, their own virtual care program de novo. And that last slide here, how are we going to measure success? This is one I've thought about a fair amount and talked to folks about. What does success look like? And for now, we're sticking at those fairly tangible items. So what are our no-show rates? What's our availability, our access? How many days until next available appointment on average? Things like that. Are people using it? What are our numbers? Can we expand hours because of it? It's an interesting one. The quality side, really working to figure out how can we study, how can we assess whether we have better diabetic control, better depression control, some of these things with virtual care, part of our delivery platform. Hospital transfers. That one I would really love to measure. I think it's going to be tricky, but we'll see. That total cost of care, that's the real question. What does it do? Does virtual care generate enough revenue to support itself? And you can see as we go on here, I get a little less specific on how we can actually do these things. Patient experience, the Net Promoter Score, I think, is a pretty decent one. But just listening to patients, of course, you can't take every comment to heart, though I sometimes do. Just reading the comments that patients leave and their experience things, I think is helpful and gives value, gives insight into what's working, what's not. Provider satisfaction, we survey the heck out of providers, so I'm a little reluctant there, but at some point I think, doing something to try to take a look at that and get honest feedback is pretty reasonable. Diagnostic accuracy is one I'm very interested in. So it's been posed to me, how often do you think the diagnosis is missed on virtual and picked up later in person? And that's something I'm trying to figure out. I think a crude method is some chart reviews, but that's one that I really like to figure out how to show that the accuracy and the quality is similar in virtual versus in person, or at least at an expected difference. So that's the information I have for the group. I'm guessing we have a few questions that have come up, or maybe comments. You can't throw tomatoes through the virtual world. I like that when I'm on stage. Sometimes it's a risk, but
I haven't seen any tomatoes so far, but we do have a few questions. And I think the first one really is based on or the same topic as those measures of success. So the question is really centered around whether there are any networks in Minnesota, the region, or nationally to explore, research these pending questions you have about whether virtual care is successful and how we do that success measurement.
Yeah, that's a really good question. I am not aware of any, conglomerates or groups that want to come together to, work together on research. When I search through, whether it's PubMed or anywhere else, there's not a lot of good data on the quality or other things around virtual care. It's a little bit scary that we're kind of leaping into this, but we don't really know the answer to those things. So I'd be very open if somebody wanted to collaborate, we could dream up some study or something, but I'm not aware of groups that at present have come together to ask those questions.
Gotcha. The next question is really around how you're incorporating provider learners into this new virtual care environment. So I know that you provide education for medical students and residents, and wondering how you've incorporated them into new virtual care, how you're teaching them when we're all in this process of learning how to do this.
Yeah, good question. So doctors, we don't like to be told what to do. And so it's a really fine line to give educational materials to try to steer people to, tips and how to have a really successful virtual visit. It could, if I just said to Doc Smith, hey, do this, don't do this, do that on your virtual visit, there's a risk of it coming off kind of patronizing or, not being received well. So what we did at Allina, we actually made a video that was kind of a good doc, bad doc back and forth. So the doc who was not having good virtual visit came in and had shadows on her face and was breathing into her microphone and had kids playing in the background, and was the connection was cutting out constantly and abruptly ended the visit. And then we switched over to the good doc who's sitting up prim and proper with the name tag and listening intently and perfectly lit room, and says, well, we have about 4 minutes to go in our visit. Is there anything else that I can help? Just this picture perfect. And so, because a lot of it's obvious, but so we tried to have this be a way that we could sort of exemplify or teach without, again, coming off as patronizing and whatnot. So that was, kind of fun. And I hope it helped people understand kind of those tips and pearls that can help make that visit as good as possible for the patient.
The next question is really around kind of your future vision for this. So with these reimbursement changes kind of being up in the air, wondering what you think is going to drive post-COVID, whether reimbursement stays the same, decreases. What do you think the main drivers there might be?
Yeah, well, I think public opinion is going to be a big time driver. Patients want it. At least they tell us they do. And judging by the number of virtual visits that have happened so far since COVID came on, they want it. What I read is that there's bipartisan support to extend a lot of these telehealth things. So I think that's all a good sign. But going back to the fee-for-service model versus more of a capitated or risk-based contract, in some ways we can control our own destiny if we're in that more capitated or whole person risk contract.
Yeah, that makes a lot of sense. I think we'll wrap things up with one final more technical question. So it's really around what the differences are between your backup video visit solution versus your primary, and kind of why people might use the backup.
Yeah, so our go-to, our main system is using Vidyo, VIDYO. It's one of the main, there's probably a dozen different video platforms that integrate. We're an Epic system, so they integrate with Epic. And if the patient has a MyChart account or what we call Allina Health account, they connect in through that, and then the provider connects in through their Epic hyperspace, and the video happens. But again, that fails more often than not. And so we use Doximity as a backup. And so docs have Doximity on their phone or on their desktop browser. And Doximity works really slick. You literally just plug in the patient's phone number. It sends a link to the patient and it says, hey, Dr. Ingham has a virtual room ready for you. Click to enter. And it may prompt them to say, access the microphone. And so while we're working things out, again, we're trying to make this as good and smooth, as seamless as possible for our patients and our doctors and advanced practice providers. And so we have Doximity as a backup. I'd like that to phase out as we get our integrated and our MyChart. We're actually switching from video probably over to Microsoft Teams for our integrated Epic platform. But as we get that to be as good as possible, we'll be able to phase out that Doximity. We will still have what we call a direct connect using Microsoft Teams, which is we're kind of sending a link to the patients who aren't in MyChart, or for niche scenarios where I need to have an interpreter on, or some different things, or certain scenarios where we do need kind of that non MyChart option.
That's right. Well, thank you again, Dr. Ingham. Big thanks from Minnesota HIMSS for being willing to present today. I'm just going to wrap things up here. So thank you everyone for attending. As a reminder, this HIMSS webinar is recorded. I put in the chat a link where you can review this webinar once it's posted, as well as previous webinars. And then just keep an eye on Minnesota HIMSS chapter's website in order to see our future webinars. We've been having about one a month so far. So thank you again, Dr. Ingham. Have a great day.
Have a good day.